today we have Professor Sunitha Chandrasekhar Srinivas with us. In her biosketch, the three specific areas she has focused on are teaching, research, and community engagement. Her diverse experiences include project, projects with the Department of Health under the India WHO Essential Medicines Program at Medicine Information Center, Karnataka State Pharmacy Council. She moved to South Africa for training the next generation of pharmacists at Rhodes University based on her proficiencies with focus on community engagement. Investing her 14 years in teaching, she earned a National Teaching Award in South Africa. Her 18 years of focus on community engagement led to recognition by Thalar's Network University Education for Transformative Leadership in Africa grant for community engaged teaching, research, and scholarship. She also received fellowship from the University of Oxford, along with international, national, and university level awards. She was recognized by the National Research Foundation for her emphasis on research in pharmacy with a rating. She remains the first woman at Rhodes University's Faculty of Pharmacy to be awarded a full professorship and a rating. In a country where there's so much patriarchy, she continues to inspire the young women of this generation to take charge and be who they aspire to be without being apologetic about what they want. Over to you, ma'am.
Ma'am, you're on mute, ma'am.
Yeah, thank you, Asna. Thank you so much for that kind introduction. And it was extremely personal. And I think what is a big takeaway for me is for young people to remain unapologetic and to keep that fire in them, irrespective of what anyone says or does in your path of the career. And therefore, that would be the biggest takeaway even before we start. And thank you for that extremely personal introduction, Asna. Much grateful for that. I'm going to share my screen. 1 second. Please let me know when you see it. Are you seeing the screen with the next slide in or the one without the next slide in?
Yes, ma'am. With the next slide in, ma'am.
With the next slide in. So let me just swap it, please. 1 second. Is this better?
Yes, ma'am.
Thank you. But I think, yeah, is this fine? Still with the next slide in or? All right, I'm going to start irrespective of what you see there because we can always swap if required. So one thing that we're going to look at today is what are we thinking about in the area of antimicrobial stewardship in this right questions, because I think while we are waiting it out, well, not everybody is waiting it out. The essential service providers and the healthcare professionals can't wait it out. They have to be in the front line. But while the rest of the world is waiting it out, it's also a good time to interrupt the noise around us for a purposeful pause. Because it's only when we stop and pause are we able to take stock of where we are and where do we want to go. So if we think that AMR is a serious health problem, I think one of the things that I want to focus on today is what have we done so far, and is it actually enough? And other than that, the next factor is, as healthcare professionals, are we doing enough to address what is called as the no-do gap? So we may know a lot, but what we do in order to respond to that no is equally important. So one section of the presentation will look at that. The third and most important one, which is why it is in bold, is are we training ourselves, or are we doing what we need to be doing in order to be AMR stewards? Because if we want to be focusing on the careful and responsible management of something entrusted to our care, then that is when we can call ourselves the stewards. So if we want to be there, then there are certain things for which we take responsibility. And once we take responsibility, we remain committed towards it. We also have to look at, in other parts of the world, whose job is it anyway? Is it just for the government to look at it? Is it just for healthcare professionals to look at it? Or does it need something different and better? But most important, I think this entire focus during the mentorship program that you're having is all about where you are heading. And as part of this, as part of what Dr. Karthik is doing towards the Pharmacon's goal of ensuring that whatever your career goals are, it's about preparing you better for those career goals, as well as it is also important to look at how do we train you in order to prepare you better. So these are some of the key questions that we have to bear at the back of the mind, and then start looking at where are we with AMR. So if you look at AMR, wherever you are, depending on whether in a hospital setting, you're in a primary healthcare setting, one thing that you get always bombarded about is the kind of significant global human and economic impact that it has. So if you look at what are the kind of damages that are happening, if our inaction towards AMR continues, then by 2050, more than 10 million people will be succumbing to the issues related to AMR. And that number will be extremely small when compared to all the other problems that we already have with respect to our burden of diseases. And one thing to also bear in mind is not just about the health impact, it is equally important to bear in mind the economic impact. So health and development will both suffer, because anywhere between 2 and 6 trillion US dollars could be the fall in the global economy, because if we are going to go along with more sickness and with the healthcare industry just becoming management of diseases rather than keeping health as the central point of that equation, I think we are asking for trouble here. So this has to now come back to where are we with respect to the burden of diseases. So if you look at where we have been going since 1990 all the way to 2017, we can see that our what we have to pay attention to is the double burden of diseases in developing countries such as India. So on one side, we not only battle with our communicable diseases, maternal, neonatal, and nutritional issues, we are also battling with the non-communicable diseases. So when this becomes the chronic juggling in the healthcare system, then the effect that it has will be enormous. The negative effect is what we're talking about. Have we been doing enough for this? And I think where we also have to ask ourselves a more difficult question and be prepared for the honest answer, and the difficult answer is it too little too late? Because if not enough has been done, and if it has not been soon enough to make a difference, then something has been not working well for us, or we have not been contributing well enough as healthcare professionals. So for every slide that I have used here, you have the URL, and the slides have already been sent to Dr. Karthik and team. So you can get hold of it if you're interested in this aspect. So you can always take a look at what is there, because sometimes the font size is small to read. If you look at the WHO website and all the resolutions that have been coming through, it only started in 1998. And until 2015, it did not gain momentum. So if we have been waiting for so long to gain that momentum, then we have already missed a big chunk of opportunities that could have happened different and better. Now, where does India stand in all of this? So if you look at the share of disease burden from communicable diseases versus the GDP per capita, if you look at the world here, India is right there. And take a look at all the other countries. Nothing matches as much as the problems of communicable diseases and its share of disease burden and what it does to the GDP is. So if we don't take it seriously, then the question is who will? Because at the end of the day, the problem is in our backyard. So what has been happening in our country? So if you look at what ICMR has been doing since 2014, you have the data available. Now, what is this data related to? It is India's antimicrobial resistance surveillance and research initiatives. And by 2015, what India started doing is having a national program basically for the public sector, which is called as the Kaya Kalpa program. And it looks at a holistic approach of not just what needs to be happening with respect to cleanliness, but it is also with respect to infection control, hygiene promotion, sanitation and hygiene, and waste management in the public sector healthcare systems. Now, this is a program that has started taking root from a national to a provincial, all the way up to the primary healthcare levels, and they are incentivizing this program. So there are awards to be won, and healthcare systems are working towards it. A recent development is to do with all the apps that have been introduced, because Kayakalpa is being linked to the quality assessment and the NQAS program, which is the National Quality Assurance Standards, and the Kayakalpa have an app called as the Gunak app. Now, this is something as the next generation pharmacists and healthcare professionals, where antimicrobial stewardship should start becoming a core element of what you are looking into. Having access to these kind of apps and being a part of the infection control committees in the hospitals that you will be working in is an extremely important element of career development that you can look at. One of the major web pages where you will find whatever is happening globally is definitely the World Health Organization webpage. So there's the link for that, and it gives you what are the current developments that are taking place. Now, it is only by 2015 that the World Health Organization Global Action Plan came about, and they looked at 5 strategic objectives, one of which is definitely awareness and understanding of antimicrobial resistance. So maybe in today's talk, I'm focusing more on this because this is more to do with ensuring that the next generation of pharmacists take up that baton and look at how do we create that awareness, how do we start having a better understanding, and then looking at a healthcare system level, what are the actions that we need to be taking, whether it is surveillance, research, reducing the incidence of the infection, optimizing the way we are using our antimicrobial agents, and more important, it is also to look at the investment in new medicines. And I'll be talking about this other than the diagnostic tools, vaccines, and other interventions. So this happened in 2015. By 2016, the United Nations Secretary General had an ad hoc interagency coordination group on antimicrobial resistance. Now, why do we need this? The reason is it's a global health security issue, and there has to be coordination between different international agencies. After this happened in 2015, India took action because India, as you know, is one of 194 member states of the WHO. So whatever policies happen at a national level and the policies that drive, though health is a state level or a provincial level agenda, everything happens based on what is decided during the World Health Assembly every year in May in Geneva. Because that's where all the 194 member state countries meet, they pass the resolutions. Those resolutions then drive all the policies that are being implemented in each of these developing countries, majorly developing countries. So India's National Action Program on Antimicrobial Resistance came about in 2017. So it is up to this year, which is 2021. But one thing we have to bear in mind here is how it is not just the World Health Assembly or the World Health Organization that is definitely looking after the health-related aspects, which looks into these aspects. It is also the United Nations General Assembly, because this is not related to health. This is related to the general leadership from all these 194 countries, and they meet in New York. For the 4th time in the last 7 decades, antimicrobial resistance issue has become one of the discussion points. And therefore, in 2016, that first resolution came about. They spoke about about how high-level meetings need to be happening and how different countries need to be taking a big part in all of this and moving forward. And in 2019, they had a follow-up of that particular political declaration. And these are important to understand. The reason is this is now not just a health issue. If it was just a health issue, then just the World Health Organization would be taking care of it for the 194 countries as a leading policy-making body. Now, because this is a global health security issue, the global leaders are also paying attention to this. And that is something we need to bear in mind. This doesn't happen lightly. And only 4 of the health issues have ever been discussed and resolutions have come out in the United Nations General Assembly. Now, other than this, what has been happening is also the focus, which is now not just on human health. The focus is now encompassing what is called as the One Health. Now, what is this about One Health? It is that intricate balance that exists between what happens in the animal world, in the plant world, in the environment, and humans. Because the antibiotics are getting into our food chain. For increased production of milk and in order to keep the cows healthy, the amount of antibiotics used as growth promoters and prevention of infections has increased. For the very similar reasons, even in agriculture, the amount of antibiotics that are being used has increased. So they're all being used as growth promoters. So it means it is entering into our body, even if it is not because of the human use, where we have been prescribed antibiotics by the physicians and then we are taking those antibiotics. The other thing very important for India to bear in mind is if there are more than 8,000 manufacturing units in India and how many of our thousands are manufacturing the antibiotics, all the effluents that come out of these manufacturing units are also getting into the water bodies and into soil. So that is something we should not forget about because it has a huge impact on how we are going to go about it. So what are we doing in here? So we have in 2017 a document that has come out from ICMR with other organizations, which gives us a good picture, a clear picture about what is happening with respect to the burden of diseases in every state in this country. But it also talks about how the infectious and associated diseases may be reducing, but they're still very high in many states. So in our health indicators, if communicable diseases continue to be the major challenge, we also need to pay attention to antimicrobial stewardship as one of the way forward. So what has WHO done with that? In 2019, this is a document that has been released which talks about in low and middle income countries, what are the kind of stewardship programs that can take place in healthcare facilities. So something good to bear in mind is these are recent developments. And it is very easy to get into the swing of things and make these a part of how we handle our systems. Are we doing this a little too late? That is a question we all have to ask ourselves and look at where other countries have been doing this, how they have been doing this, etc. So one thing to bear in mind is as the next generation healthcare professionals, do keep in mind the WHO health system framework, because this is a framework that looks at what are those building blocks that we need to focus on. And based on focusing on those building blocks, how will we be achieving the overall goals and the outcomes that we need? And one other aspect to also react to is we have somehow accepted the fact that this pyramid of healthcare system will continue to exist. If we accept that pyramid where all the healthcare professionals have to kind of fit into that pecking order, and we just leave it up to the physicians to be at the top of the pyramid, as much as it is an injustice to the healthcare professionals and healthcare providers in general, it is a total injustice to the patient and the population-centered care that we have to look at. So the only way this can work is by having a team approach rather than by having that pyramid approach. And in a team approach, it is equally important to understand the limitations of what we know, what we understand, and what we can do, while we also look at the magnanimity of human resources to say that we all have different strengths. It is not about a competition that needs to be happening between different healthcare professionals and what they should be doing. It is consistently about the collaboration that needs to be happening. So if we need to collaborate with another person, the ego that we have to not be carrying to work needs to be left behind somewhere else, because this is not about who is better. This is always about what is the best for the patient. So if what is best for the patient is our central point, then the way we think, the way we speak, the way we operate, all of that will take an enormous change. Now, what have other countries been doing? So I've just taken up the example of United States here. So in 2013, they had this antibiotic resistance threats. And then in 2019, they have updated this. Now, by doing this, where are they heading and what is happening parallelly in the WHO? For example, in WHO, what they have done is they have the global priority list of antibiotic resistant bacteria to guide research, discovery, and development of new antibiotics. Now, where I'm trying to bring all of this is, do we know enough about what we need to know? Yes. The answer to that is yes. Are we doing enough in that no-do gap? The answer to that is definitely a big no. And that is what is being questioned and answered consistently throughout my presentation. Now, in CDC as well, what they have done is they have classified into the urgent threats, the serious threats, the concerning threats, and the watch list, because it is all about keeping a vigilant look at what are these antibiotic resistant bacteria, because that is going to guide how we do what we do in the healthcare systems, as well as outside of the healthcare systems in the communities. But where I start finding a lot more what I call as a very focused approach is more in the World Bank documents. So if I look at this particular one, which talks about pulling together to beat superbugs, it very clearly states and brings together the synergy between health and development. There can't be development if we're going to be a nation of sick people. There can't be productivity with sick people. If we continue to use our healthcare systems to be disease management systems, there cannot be healthy people. So the focus has to be on health. The focus has to be on infection prevention and control. The focus has to be on antimicrobial stewardship, which includes prevention-related aspects. So this is one of the best documents that speaks to that the collaboration that needs to be happening between health and development. And what is very nice here is it gives an excellent schematic representation where we look at what are the different antibiotics, when were they discovered, and when was the issue of antibiotic resistance detected. And therefore, once we start seeing the resistance being detected with all the antibiotics that we have, what we also need to bear in mind is the cost-effective antibiotics that have been in the market for a long time are becoming useless, which means the antibiotic void, the discovery void that has been going on for a very long time, where we have not invested money on inventing new antibiotics, is going to be a very costly outcome for this. The other thing I find extremely interesting in this particular the World Bank document is how they talk about the Sustainable Development Goals and AMR. How AMR has an influence on some of the Sustainable Development Goals, and how some of the Sustainable Development Goals, when we start achieving them, will have an impact on AMR. That's a very interesting schematic representation there. Again, going back to, do we know enough? Yes, we know enough. Because if you look at this same document from the World Bank, it talks about 6 priority areas for AMR research that needs to be done. So what we have been doing until now is we have been prioritizing the problem. We have been looking at what are the ways to go ahead to address those problems. But now we need more shoulders to the wheel rather than spanners to the wheel. So the only way the shoulders can come to the wheel is when the next generation sees the importance for this, and other than seeing the importance, starts becoming a part of the healthcare team that has to work towards it. So one other group that is doing excellent work in this area, sorry? Okay, the 3-dot option, what am I looking for here? Yes. So can you see this now? These are the options that I see. Change layout. I'm off screen now. Okay. Um, so the entire time you have not been seeing the slides, is it? Okay. Okay. So your entire screen, yes. So it says share. Is that fine now? Yeah, I've clicked on it. I'm waiting for it to. Yeah. Right. I do see one here. Right. Yeah. I've clicked it. Hide presenter view. Okay. If I do that, I can't hear you well. The PowerPoint option, what has happened is it has gone onto my other screen. I have two screens on my computer, I mean, on my table here. So the presenter option is now on the other one. I didn't hear you well. If I hear your instructions clearly, I can do this. I'm unable to hear your instructions clearly. Can you? Yeah. If you speak up, I am able to hear you. Yeah, please do. Yeah, I've selected my entire screen. Yeah. Yes. Yeah, I've done that. Is this helping now? Yeah, I've clicked on the slideshow mode. All right, thank you. So the other organization, I apologize for this interruption. The other organization that has been working a lot in this area is the Access to Medicine Foundation. So when you look at the Access to Medicine Foundation, which is based in Amsterdam, they have the Antimicrobial Resistance Benchmark 2020. And what they're doing is they are giving a scorecard for all the top industries, pharmaceutical industries, based on their approach towards addressing antimicrobial resistance. So it's a very interesting website to go and see. And what is becoming clear is the number of industries that are sharing the raw data on the spread of resistance needs to increase. And Pfizer became the first company to share their raw data on the spread of resistance. And it also shows between 2018 and 2020 how there are programs coming about where they are not just looking at stewardship plans from the industry, they're also looking at access plans so that access to antibiotics are also being addressed. Now, what do we need to be doing for stewardship? What are the steps we need to be following? Definitely research and development. Definitely regulation and manufacturing. How we select our antibiotics. What is the procurement and the supply, distribution, prescribing medicines and diagnostic that needs to happen in healthcare facilities. How we dispense it, and definitely how the users, the end users, are using it. Now, one thing I would like us to look at is if we look at India, for example, we will be under the type B countries. The reason is the level of antimicrobial use is very high here. The exposure to other contextual risk factors is equally high here because the social determinants of health being what it is in this country. The expected level of AMR risk is equally high here. So if we are in this type B country, and if we continue to ignore antimicrobial stewardship, then the mistake that we are making, we may not be paying the price for it, but the coming generations will definitely pay the price for it. And I don't think we have any authority to make that happen. It's in our benefit in order to start addressing these issues. Now, I had one of the questions I had looked at in the very beginning is who are the different people who need to be involved in this? So if we keep pointing fingers and blaming and saying the government needs to do this, the doctors need to prescribe better, the pharmacist should stop dispensing 1 or 2 antibiotics when a patient complains of cold and cough, the patient should complete their treatment, the blame finger will never stop. Every time we point a finger at somebody else, there are 3 pointing at us. So we need to look at how do you and I as individuals, how do you and I as healthcare professionals start looking at this entire group of key stakeholders we need to be working with. And key stakeholders include industries. Key stakeholders include from the One Health program where we have to look at how antibiotics are being used for animals, for plants, etc. So everybody is required for this. The other key point for healthcare professionals is also to look at what is the FIP development goal. This was released in September 2020. So linking the FIP development goals along with the sustainable development goals is extremely important. So this is a key goal setting area, if you ask me, for the next generation, where you identify what are your strengths, where do you think you fit the best, and how can you start utilizing those as your priority areas of career development. Again, this is from FIP. They call this the 5P activities, which is how do we need to change when we look at AMR. Policy is something we need to really be focusing on. Patient, definitely. Pharmacy, prevention, prescriber. These are the 5Ps that we have to be working towards. Now, when we work towards these 5Ps, what are the different frameworks that need to be happening, right from educating healthcare professionals, enhancing communication skills. It's only when we are able to communicate are we able to really get things done. So all of this plays a major role. Where did this journey start for me is definitely when I was working in South Africa, because it was in 2011 that the first situational analysis of the status of AMR started at a national level. And then by 2014, the AMR strategy framework was approved. So since 2014, this has become a part of my teaching activities. And after 2015, it has also become a part of the research-based activities. And then this journey has continued. And from that journey came about what I've started doing in India from 2017. So having stewardship programs for practicing pharmacists, publishing in this area with my postgraduate students, for example, the antibiotic procurement and ABC analysis in Eastern Cape, working in primary healthcare centers in Karnataka through Karuna Trust, an NGO that manages this private, it's a public-private partnership program, and basically classifying the antibiotics that they are using at the moment into access watch categories, because reserve category of antibiotics are not supplied to them, fortunately, at the PHCs. So just creating that awareness of how do we reduce the use of fluoroquinolones, for example. And these are the kind of things that we are looking at. Now, health events are also taking place since 2018. These have been going on. And what we are definitely planning on is the IPA CPD program, launching this on the 28th of March, because we want this to become a central point of what IPA CPD is doing, and we are all gearing up for that. And that's exactly where this is like a soft launch, where we are making you all aware of what we are working towards and how we would need each one of you to be working with us towards the same goal. A lot has also happened before this. And as with everything else in life, thanks to COVID, things have come to a standstill. In 2019, we had this program at Karnataka State Pharmacy Council. It was a key stakeholder program. And we are looking at a state level antimicrobial stewardship policy, etc., from Karnataka itself. So things have started moving, but the momentum was lost. And now, when we have the next generation pharmacists join us, I think the momentum will come back. What is even more important is when it is not just limited to the pharmacists, but we are working in collaboration with the entire healthcare system and all the other people that I was talking to you about, that is when the real collaboration happens. Now, as a last point, India is a young country. We have the largest young workforce from the year 2020. If at this point we don't make use of having that young workforce to be looking at where we want to go, I don't know when else we will do this. So we rather take this up at a time when there is youth and youth power working with us. Surely during a pandemic, the next generation leaders don't have the time to grow up slowly. All of us are corona warriors, because as much as the leaders in the health sector are standing in the front and making things work from there, everybody else is putting in there, pitching in for themselves and looking at it. One thing to bear in mind is every crisis is also an opportunity in disguise. So if we just keep looking at it as a crisis, then we have lost the opportunity. So we better start looking at the opportunity. And the only way we move forward is with the philosophy of I am because we are. This is not about territorial spaces. This is not about who is better than who. This is not about who knows better. None of that. This is all about united we stand. We have to watch our thoughts, because thoughts become words. Words are actions. Actions are habits. Habits are character, and character is destiny. But two proverbs I would definitely like to end this with are: if you want to go fast, go alone. If you want to go far, go together. Going together is quite painful because you have to take into consideration a whole lot of factors, and human dynamics is funny and terrible at the same time. So it has its downfall, but if you want to go far, that's the only way we can go. Something to always bear in mind: you can't always end the journey with who you start. So be willing to walk alone. Many who started with you won't finish with you. So it doesn't mean you stop walking. You have to continue that journey if you believe in it. And it is not just about the journey, nor is it just about the destination. I think what is extremely important is the companionship on the way. So who are the people you start working with, and how you integrate into that common space is what it is all going to be about. So with those few thoughts, I would like to leave it at that and then take it forward by working with all of you who would like to be volunteering into this program as a part of what we will do as a mentorship program, and looking forward to bigger and better things to come our way. Thank you so much.
Yeah, thank you so much, ma'am. So I think we will take questions at the end, ma'am.
Definitely. Sorry,
Dr.
because of
Gautam
all of
section.
these confusion, we have lost time. So
Yeah, ma'am. So Dr. Gautam, if you can introduce and start the session.
yeah. So this is an extremely important space, because we are not just looking at the theoretical aspects of where are we and where are we going. We are now going to be looking at the practical aspects of what is it that is widening the gap between the know and the do. And introducing Dr. Gautam is not just a privilege from being a trusted colleague with whom I have been working for the last 1.5 years, but I think what is equally important is having a committed and a compassionate physician who not only leads the efforts in the antimicrobial stewardship aspects, because he is, of course, the clinical assistant professor at the Division of Infectious Diseases and Global Health. Other than that, he has a lot of interest in the TB-related aspects, but most important is all the efforts that he's putting into the COVID forum that is happening on a weekly basis. So a whole lot of this is not only to inform you about what is happening in the international scene, but it is also to introduce the kind of work that Dr. Gautam has been spearheading with all of this. So Dr. Gautam, thank you so much for making time. Apologies for the late start, and over to you, please.
Thank you, Sunitha, for the kind words. And I was wondering, can you all see my screen? No? Yes, sir. Is it the slide that you see?
Yeah, now we see the slide.
You see the slide, yes?
Yeah, we do.
Yeah?
Yeah.
Is that clear?
Yes.
Yes, sir. Yes.
Okay. So thank you, Sunitha, for those kind words again. And it's an honor and privilege to be part of this mentorship program. I think I won't repeat what Sunitha has already emphasized, that antimicrobial resistance is a huge problem for all of us, and more so in developing countries. So I'm going to present a small project that we did in our division of infectious disease, looking at patient safety reports and Sentinel events influencing antimicrobial prescribing in a tertiary care hospital. Right. So does anyone know who this is?
No,
Any
sir.
guesses?
No, sir.
No,
All
sir.
right. So so this is George Orwell, right? The famous Scottish writer. And the reason I have his photograph here was he probably was one of the first people to actually succumb to antimicrobial resistant bugs. Right. So the story goes, he was diagnosed with tuberculosis in his early 40s, those days there wasn't much of treatment other than fresh air and painful surgeries. So he was in a sanatorium in Glasgow, and then streptomycin came along. It was only available in America at that point, and people had heard of its miraculous benefits. Unfortunately, he was in England and he couldn't get it because it was too expensive. But using his personal contacts, he got it, and he was started on streptomycin for a few months. Had a remarkable recovery, but then developed what now seems like a Stephen Johnson syndrome. He had rashes, he had blisters, dermatitis, they called it, and then he stopped. Started, within those 2 months, did really well, and then had to stop it. And then again, his disease got the better of him. A few years later, PAS was discovered, and again, wasn't available in the UK. So he made special arrangements, considering his influence, to bring it to the UK, and was treated with it again. But I think, as all of you all know, PAS isn't an easy drug to tolerate. So there he stops it and then succumb to his death, probably more so from resistance as we know it, right, from tuberculosis and multi-drug resistance. So he just got one drug, stopped, got the other drug, stopped, so probably had a multi-drug resistant bacteria. So I just have a cartoon here, and I won't dwell too much on antimicrobial resistance, because I think Sunitha has just spent the last few minutes or half an hour talking about it. But what is it? It's a natural process where microbes evolve to be able to resist the action of drugs, making them ineffective, right? Now there can be lots of mechanisms, transfer of these mechanisms from one bacteria to another, but also one of the most important thing is the selective pressure. So when you put someone on antibiotics, there are a group of bacteria that are inherently resistant to some of these drugs. And if not treated properly with poorer courses, then they form a bigger inoculum as such with those resistance mechanisms. And that's how they propagate, amongst many other things. And we'll come back to that. So it is a big problem. Governments across the world take cognizance of the antimicrobial resistance. The UK probably, spearheads a lot of these policy matters, and they did form a national commission in 2016 to talk about antimicrobial resistance, not just in the UK, but in a global scenario as well. So again, this is something Sunitha described a little while earlier, but it is a big problem, and it's a problem across the world. There are people who think that about 500,000 people die every year from antimicrobial resistant bugs. Now, that could really be an understatement. There are probably lots more people who die from antimicrobial resistance and probably indiscriminate use of antibiotics. So people say there might be about 10 million people who will die every year from antimicrobial resistant bugs by 2050. And the cost, if if the cost is going to be about 100 trillion US dollars, might be that's the global thing, but every country, I think, will take cognizance of both the debts and the amount of money it would cost the healthcare systems. So, as you probably know, it's not just humans, and that's where the concept of One Health that Sunitha spoke about comes in. We humans just account for about 25%, but it's the farmed animals, it's agriculture that contributes a lot more in terms of antimicrobial resistance. Now, you would be surprised, antibiotics are just not used to tackle disease in farm animals. It's actually used as a growth promoter. So chicken, lots of these industrialized farms use antibiotics for growth purposes more than antibiotics itself. So some of the problems are also related to point of care diagnosis, right? And so I have a photograph of the Gene Expert machine. So again, it's revolutionized tuberculosis care across the world, and especially in developing countries. So earlier, you had no idea to know that the bug was resistant. So you just waited, you tried therapy. If they didn't get better, then you probably sent these specimens to the specialized labs. But point of care testing, at least with tuberculosis and some other bacteria like MRSA and such, can give you results immediately. And so you know to tailor therapy, to streamline therapy, and you can do it much better. So we have a panel that we usually get. If the blood cultures are positive, it usually tells you if a MEK-A gene was detected within about 24, 48 hours. So then you know it's MRSA, or methicillin-resistant Staph aureus, versus just methicillin-sensitive. So that way you tailor therapy and you don't continue empiric therapy for too long. Right. So again, I won't dwell on this too much, but Sunitha has gone through these, the different policy matters and ways we can tackle antimicrobial resistance. But I think one thing that we are very clear is that we know that you cannot fight this battle in different isolated spheres, right? You need a multidisciplinary body or a committee in a hospital or in a healthcare setting to kind of come up with these things. And why is that? Because truly antimicrobial resistance or antimicrobial therapy depends on a whole bunch of things. You have to know the bacteria or the virus or the fungi. So you need to know the microbiology of that. You need to know the host. Now, would I worry about a 35-year-old guy with a skin infection as much as I would worry about a 24-year-old with a heart and lung transplant? So the host differs. And so you need that clinical perspective there. Would you need the pharmacy? Absolutely, yes. One of the most important parts there, right? Because the pharmacist would understand the drug, the pharmacokinetics, and the pharmacodynamics of all these drugs. So it truly needs a multidisciplinary approach. And please feel free to stop me with any questions you have. You can just raise your hands, but and just ask me any questions. Right. So let me give you a brief introduction of this study. Right. We know antibiotics can have significant side effects, and they range anywhere from leukopenia, thrombocytopenia, mild reactions like rash, to life-threatening reactions like anaphylaxis and conditions like Stevens-Johnson syndrome. Right. So antibiotic stewardship committees utilize guidelines to prevent emergence of drug-resistant organisms. So we have at our hospital, which is a large tertiary hospital with almost close to 2,000 beds, we have an antimicrobial stewardship committee combined, made up of clinicians, of pharmacists, microbiologists who meet every day in the morning. So they have a huddle for about an hour and they find out what medicines are being used. We have an electronic medical record system that pops up every time a carbapenem is used. So we kind of review those things and then get back to the teams taking care of these patients. But anyway, not to get sidetracked, but we do have guidelines that you know, we request physicians to follow. Now, it isn't a hard stop in any way, but we request physicians to follow guideline-based therapies. Yeah. Now, we wanted to see if patient safety reports and Sentinel events changed prescription habits of physicians. And I'll talk a little bit about the patient safety report. So what is a patient safety report? So anyone in our hospital can file a patient safety report. It can be the transport person. It can be people who clean the medical technicians. Anyone, from physicians to non-physicians, anyone can file a patient safety report. And it's really a non-punitive, confidential program. So we basically want to avoid any harm to the patient. And what we do is we just talk, if we do get a patient safety report, we investigate that, we look at it, and kind of just have a talk with the parties involved. Now, what is a Sentinel event? An adverse event that can cause death, permanent harm, or severe temporary harm for which a life-saving intervention is needed. So Sentinel event, one example would be someone you started on an antibiotic that developed kidney failure and then had to go on with dialysis. Now, permanent or even for a few months would be a Sentinel event. So we looked at all physicians in the infectious disease department who had a patient safety report or a Sentinel event, which means they had some problems with all of this. Antibiotic prescription, rather. So again, we got IRB clearance in 2018. We interviewed all the faculty and trainees at the Division of Infectious Disease and Global Health, and it was a structured interview which was taped and then transcribed. The two PIs conducted the semi-structured interviews, and then we used in vivo to look at the thematic analysis. So in brief, we got 17 fellows and faculty to be part of the study. 29% of the participants had been practicing infectious disease for 1 to 3 years. So they were recent graduates in that sense. 41% had been practicing for more than 9 years. So they were more senior. And all of them at least reported one Sentinel event. Now, it would be interesting, right, to see whether experience in taking care of patients gives you the courage to be, or makes you a little brave with antibiotics, and how that changes prescribing habits. Now, if you're a recent graduate or a recent trainee and you developed some serious side effects, then you might be a little more cautious about using some antibiotics versus the other. So 16 or 19% changed their practice after a Sentinel event. So that is big, because it is one thing to expect doctors to follow guidelines and follow certain antimicrobial resistance stewardship guidelines and kind of be careful with antibiotics, save the more recent ones, the later generations ones. But then what happens when you have someone you've tried these antibiotics with and they develop life-threatening emergencies? It does, most of them said they changed their practice. They started doing things differently, which would make sense. 8 or 47% increased the frequency of ordering lab tests. So they became, the way they changed their practice was they decided to be more hyper-vigilant, so ordering more tests. 41% indicated they may change antibiotics for more expensive antimicrobials with better safety profiles. So cost is a big thing in the US, and some of these antibiotics talk about a huge difference. So say if you want to keep someone on vancomycin for 6 weeks, I'm just making up a number, but it might be about $2,000 or $3,000 versus daptomycin or ceftaroline, which then might be about $14,000, $15,000. And that might, that is quite the difference there. A lot of times when insurance companies have problems, you don't get, it becomes a huge burden for patients to kind of pay for these expensive antibiotics when you could have used something cheaper. So about 47% of the participants endorsed hypervigilance while using antibiotics, which was some of the things that I had alluded to earlier. So we did a thematic analysis and we came up with these sub-themes, which was communication, investigation, medicine patients, and frequent clinic visits. So what was interesting amongst all 16 or the entire study group was there was just one person who said he was worried about antimicrobial resistance being one of the ripple effects of changing antibiotics, but the others didn't really consider antimicrobial resistance as a problem. So with Sentinel events, with problems that they experienced, they were more cautious about antibiotics primarily, or what was driving their change of using antibiotics was mostly their bad experiences rather than antimicrobial resistance itself. And this might be different in countries like India and countries like the US. The US has a lot of problems with litigation for healthcare professionals. So you have to be careful, right? You could get sued for millions of dollars. So the consideration would be to be safe rather than worry about antimicrobial resistance. So let's look at the sub-theme of investigation, right? So, and I'll go through these in a little bit of detail. So creatinine levels and renal failure. So this was mostly related to vancomycin. And now we're seeing probably cefpime and some cephalosporins as well. So the vancomycin, obviously, as all of you all know, can have some serious effects with the kidney, causing acute kidney injury. We've had many patients who go on vancomycin, their creatinine goes up and they end up on dialysis. So that's one of the side effects. But considering how many patients we send out on vancomycin, that number is really low. But still, if you have someone who ends up with dialysis, then I've heard a lot of my colleagues say they would rather use daptomycin, which is a lot more expensive and not really approved for some infections with MRSA. So, that's, and they've been extremely hypervigilant about the creatinine. So that's one of the big problems, renal failure and creatinine. So hypervigilance. So once you have someone who has this acute kidney injury or thrombocytopenia, as you would see with linezolid, you would start getting labs much more frequently. So ideally, under an OPAT system or the outpatient antibiotic treatment system, we get labs once every week. So someone goes into their homes and gets the labs and then comes back, right? But if you've had trouble, you might just say, I want to get labs twice a week. Now, what is the problem with that? There's cost, right? Because someone has to go to these patients' houses. Some of them live far away. So, and eventually someone pays for it. So there's cost. There is inconvenience. What if this person is working? All right. He, has to stay back till the nurse comes and draws the blood at his or her home, and then he leaves. So there's inconvenience. And then with frequent labs, you can have errors, which then probably make you investigate and kind of sets you down a path of more lab work, more investigations, and more inconvenience and cost for the healthcare system. So I think the hypervigilance, lab values, and monitoring kind of are broadly under the hypervigilance sub-themes itself. So again, there were very few people, and we thought that they were mostly the senior physicians who said, I'm okay, even if there's acute kidney injury, if there is renal failure. It happens once in about 100 patients, but I'm not going to change my practice. But again, that comes probably with experience, right? So let's look at some of these sub-themes here and what made people choose antibiotics differently. So there's the concept of cost. So obviously, you want to treat patients with the best antibiotic that is good for their infection that they have, but you also want to consider cost, right? So say, for example, you want to treat certain bacteria with just penicillins. You don't want anything more than that. Syphilis, neurosyphilis, you want penicillin. Now, based on your experience of having a bad outcome, many physicians chose a more expensive antibiotic, which was less efficacious. So obviously wasn't doing justice, right? You would choose a antibiotic with a better safety profile. And again, going back to vancomycin and daptomycin or ceftaroline, right? So vancomycin doesn't have a very good safety profile in that sense. With kidney injury, it needs close monitoring. Vancomycin has been it's an excellent drug and we use it all the time, but certain physicians probably felt that daptomycin had a better safety profile than vancomycin, so they used it even when it was probably not indicated. Again, efficacy is the same thing. Again, inpatient versus outpatients, would you use more oral antibiotics as an outpatient? You probably would. And again, the sub-theme of named antibiotics was, I think, had to do with people naming the trade names of antibiotics. So if you had a patient who had acute kidney injury from any antibiotic, right? Because all antibiotics in some way or the other could cause acute kidney injury. It could cause, say, CNS effects. It could cause thrombocytopenia. So all these side effects, would you start getting specialty consults, and would you want them to be seen in your outpatient clinics more often? So let me give you the background. So when I see a patient in the hospital or clinic, I probably see them in the hospital. I see them for a week, diagnose what they have, put them on antibiotics. And for people who need antibiotics for 4 to 6 weeks for either osteomyelitis, endocarditis, brain abscesses, we send them off with a PICC line with antibiotics to continue for 6 weeks at home. Now, we get them back to our clinics to see them in about 2 to 4 weeks. That doesn't necessarily always happen, and primarily because ours is a very busy hospital, and we just don't have the slots to see patients when they come in. It's a question of bandwidth. So then, what happens? So if I am discharging a patient outside with antibiotics and they are not going to be seen in the clinic in 4 weeks, I am a little worried because I don't know what's happening in the house. Is the patient taking the antibiotics? Is the wound getting better? Are they feeling better? So one of the things we saw was about 65% of the people we interviewed spoke about wanting frequent clinical visits and how much of a concern it was that they wasn't available as much as they would have liked it. And again, this isn't universal, it's not general, this was just at our institution. Again, coming to consults, just because you've had a side effect. Now, suppose someone has neurotoxicity from one of the antibiotics. If someone has had thrombocytopenia, leukopenia from one of the antibiotics. If someone has had acute kidney injury from one of the antibiotics. Are you going to get these consults? Are you going to go get a nephrologist to see them? Are you going to get a hematologist to see them? Are you going to get a neurologist to see them? So we saw that only about 12% of the interviewed physicians stated that they were willing to get consults. Now, this is interesting because, again, as it boils down to everything, it comes down to cost, inconvenience, right? So if you get a neurologist to see someone who's developed some neurological complications from one of the antibiotics, they're going to order a whole lot of tests, right? An MRI costs close to about $7,000, right? A CT scan costs about $3,000. So if you're going to get all those things done, this might have been something very simple, but then you're adding to the cost of healthcare itself, right? So this was interesting, and we were pretty happy with that. So anyways, coming to the conclusion, what did we make out of all of this, right? So that social and behavioral factors can influence the clinical decision-making process, such as beliefs, emotions, experiences, and biases of the prescriber. So even if there are international organizations, even if you have committees in the hospital telling you, giving you the guidelines and telling you that you shouldn't be using higher generation antibiotics, right? A lot of what happens is based on what the physicians experience on a day-to-day basis in terms of treating their patients, having side effects, having serious side effects. So all those things factor in when physicians prescribe antibiotics. It's just not what they're told to do, right? And so we also saw that physicians really want an actual OPAT program in every hospital so that it makes it easier for them not to be hypervigilant. So we found that Sentinel affect physicians' prescribing practices and monitoring of antimicrobial therapy. And this alludes to what I spoke about earlier about being hypervigilant and changing antibiotic therapy. So again, one of the things we saw, they wanted closer follow-up. So if you had a side effect that was bad, you wanted to see them in clinic every week versus someone who didn't have any side effect, you would see them in about 4 weeks. So these were some of the things that altered the prescribing habits of infectious disease physicians with antimicrobial resistance. So a quote from Tom Barbara: "The dream is real, my friends. The failure to make it work is the unreality." And with that, a big thank you for my collaborators at the University of Florida. It was Dr. Archibald Lennox, Dr. Zareen Zaidi, who is with internal medicine, Dr. Andrew Abbott, who is now with the CDC, and Shraddha Patnala, and last but not the least, Dr. Sunitha Srinivas, who helped with the thematic analysis. So with that, I will take any questions.
Okay, just to beat the silence, maybe I can start with one, Dr. Gautam. What would be the way forward when you look at this kind of data coming from your hospital? What do you think would be the most feasible way forward for you as a team? I'm not asking you as a clinician and what you would be doing, but as a team, what would you be doing moving forward?
So one of the things we do is with these kind of patients, we sit down with the entire team, which would include a microbiologist. We would get the we have infectious disease pharmacy fellows. So pharmacists who are doing the infectious disease fellowship. We have them when we round. So there's a lot of interdisciplinary interactions, which I think help kind of mitigate some of these effects. So again, right, these are facts. So they are going to change their practice habits, but how much of that can be mitigated with data, with facts? So with, in a patient who has, say, kidney failure and has edema of his intestines or his stomach, there's going to be edema there, right? In a patient with, say, with cirrhosis, there's going to be edema. So is the absorption of oral antibiotics going to be as good as IV? Probably not, right? And so those are some of the things we sit and talk and, nudge each other. So even though I might say, I've had this bad experience with this antibiotic, I really want to, use something safer. Someone will say, what, do you think this is a good idea? We can monitor that very closely. So again, coming back, I think closer monitoring is, if you put in an OPAT system in a hospital. Again, just to give you a background of what an OPAT system looks like. So again, it consists of a physician, a nurse, pharmacist, and they look through all the patients who have been sent out on antibiotics once a week. If they see a lab value that is worrisome, then we call them, we talk to them, we talk to the company that's giving them the antibiotics just to make sure that they're on the right dose, haven't missed a dose, And if it looks serious, we get them in. So we just monitor them very closely, right? So having that OPAT system helps us say, you know what, let me send this patient on this antibiotic, even though I'm a little worried, because there's someone who's going to keep an eye on them. So it's just close monitoring. And then it's, again, like I said, having an interdisciplinary, multidisciplinary committee that you kind of discuss freely about what's best for the patient. Because at the end of the day, it's patient-centered care. You want the patient to get better. It has nothing to do with anything else. You want the patient better. And if the patient gets better with something that's not in the guidelines, so be it. But finally, it's patient-centered care.
Dr. Karthik, I saw a question come up on the chat box.
It was about iron supplements in patients receiving an antibiotic.
Sorry, I didn't hear that well. I don't know about Gautam.
No, I didn't.
So a student was asking, why can't we prescribe iron supplementation for a patient who is on antibiotic in most of the cases?
Iron supplements?
Yes. Yeah.
Okay. I mean, if they have iron deficiency anemia, then yes. But also bear in mind that a lot of antibiotics have interactions with minerals, right? So you want to be careful when you want to dose your antibiotic in relation to, say, iron or any cations. So if the patient does have anemia and requires iron, there is probably no reason why you shouldn't. But I'm not aware of any data which talks about iron for side effects associated with antibiotics. I don't know if I gathered that question right, but that's yeah.
So any
Good
more
evening,
questions?
sir.
Yeah.
Sir, I have a doubt, sir. When we use antibiotics, there are certain cases where we find after using for 1 or 2 days that those antibiotics are not suiting the patient. For example, they might cause allergies, or they could not be necessary, and we find out later, or they may cause severe diarrhea. In such cases, should we stop using antibiotics, and though they may cause resistance, or should we continue the therapy, sir?
So I think, Sashri, you bring up a very, very interesting comment. Great question, right? So a few things here. So most guidelines suggest that you treat someone empirically for a few days until you have enough data to then use targeted therapy, right? Now, if a patient comes in really sick, you want to treat this patient with the entire spectrum of what you have. Like, say, for us, we cover the gram positives. We look at MRSA if they, so we don't use anti-MRSA therapy for everyone. We have certain criteria that we use, but say they fit into that criteria, we would treat them with anti-MRSA antibiotics. We would use antibiotics for the gram negatives. We might use antibiotics for the anaerobes as well. So that's empiric therapy. Now, say in about 2 days, in about 2 days, you have more information. Now, the blood culture is growing a gram negative. It's, it's probably a urine infection. It's probably cellulitis. Then you kind of streamline your therapy to basically treat that infection. Right now in terms, it's okay. So you can do that. Now, if you have reactions and usually a rash, it really depends on how serious the rash is. Now, if it's just a small little itching, you could give Benadryl, and we might do it if rather than go, say, from jump from one class to another, we might just treat with some Benadryl and treat. So it really depends. And that's why I said it depends on the host. So the clinician knows what the host is, right? Is it a transplant patient? I would want to, I wouldn't worry as much about cutting down on antibiotics in a transplant patient. Whereas if it's a young guy, 18 years old, I'm not really worried. Then I might peel off these antibiotics, and it depends. But also bear in mind, just because you even have a severe reaction to penicillin when you are a child does not necessarily mean that you will have that reaction when you're 20, 30 years old. In fact, the rates for these anaphylactic reactions even decreases rapidly over a decade. Right? So those are some things you want to be absolutely sure. You want that information. Okay, you are allergic to penicillin, but what did it do? Was it just a small rash? Did your throat swell up? Could you not breathe? Those are some of the questions you should be asking. Now, diarrhea is an extremely important thing, primarily because of C. diff, right? And it's a huge problem, costs a lot of money in the US at least, and it can cause death. So every time I have someone on antibiotics and they have severe diarrhea, I always worry about C. diff. And what are the culprits? Ceftriaxone, fluoroquinolones, clindamycin, those are some of the culprits. Right?
Thank you, sir.
Does that answer your question? Yeah.
Yes, sir. Thank you, sir.
I saw a few messages on the chat box, Karthik. Do you know where I can look for that?
So I can read it out, sir, for you.
Yeah, Karthik.
Drug of choice for MDR TB.
Right. I think that's a complete lecture by itself, but we've made a lot of progress, right? We went from, and it depends whether it's MDR, pre-XDR, or XDR TB. We use close to about 8 antibiotics with aminoglycosides. And so most of the side effects that you saw with the treatment of MDR TB, loss of hearing, was all associated with the aminoglycoside use. We've come to a point where we've made significant progress in decreasing the duration and the number of antibiotics. And so what the WHO and the CDC now recommend are mostly oral therapies for drug-resistant tuberculosis. And the number has come down and the years has come down as well, because I remember treating an XDR patient for 2.5 years. So much better. It's in months now.
So Lavanya, I think you can unmute and ask the question.
Good evening, sir.
Yeah, Lavanya.
So generally in hospitals, we give only common type of antibiotics for everyone, no, sir. So by following only particular guidance for particular disease, can we control the use of antibiotics?
Yeah, I think that's the whole point of antimicrobial resistance stewardship committees and such, right? So you're basically setting the tone, and again, that truly depends on the antibiogram, right, of your hospital. So the antibiotic that might work for your hospital may not work in another hospital, even in the same city, right? The antibiogram in Delhi is probably very, very different from the antibiogram in Bangalore or Mysore, right? So you can't really have a one size fits all in terms of an antibiogram. And that is why it is so important, right? We have, ours is a big hospital. We have close to about 340 ICU beds, right? So we just have many ICUs. We have the burn ICU, all of them. And we have antibiograms for each one of those ICUs. So basically means that just because we are, even in the same hospital, the ICUs, so we have across the street, right? Different ICUs, and they're all vastly different. So we look at antibiograms there, and then we might tailor therapy. So again, you can't have, yes, guidelines are guidelines, right? And by the name itself, they're there to help guide you, right? They guide you through all of this. But does that mean there's one size fits all therapies everywhere? No. So that is why antibiograms are the most important thing in all of this.
Thank you, sir.
Medini, you can also unmute and ask. I could not completely understand your question. So if you can unmute and ask, that will be easy.
Hello, sir. This is Satya,
Yeah,
a
Satya.
PharmD graduate.
Hi, Satya.
Sir, it's so good to hear you from the UF, sir. So I've been there at UF for 9 months for an international internship under
Oh, you were
Dr.
at
Lamba.
UF?
Yes,
At the University of Florida?
yes, sir. Yeah, I've done
Oh,
my
wow.
international internship. Yeah. So you might be knowing about Dr. Larissa Cavallari and Dr. Lamba, who works in pharmacogenomics and precision medicine branch. So it's right
No, I don't.
below the chance. Okay.
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 So yeah, no, I don't, but I work with Charles Pelequin.
Oh, okay. So it's like I've seen the Century Tower in your presentation, so it reminded me that.
Yeah.
So good to hear from you, sir. So I have one question, sir, like a practical scenario. So recently, one of my friends met with an accident. So and the next day, his situation become so worsened, and he developed a systemic infection, that is sepsis. Then physician advised for an antimicrobial susceptibility test. But the problem here is the turnaround time for antimicrobial susceptibility test is 72 hours. Like hospital said like that. I don't know exactly what is the standard time and all. So meanwhile, the patient is on infusion loads of broad spectrum antibiotics. So after 3 days of waiting of results, the laboratory reveals that he is extensively drug resistant infection, which is a Klebsiella infection, and is only sensitive, and the pathogen is only sensitive for colistin. So this is a condition. So these conditions like sepsis, where immediate intervention is needed, immediate antibiotic is needed. Meanwhile, they have managed with vasopressors, but then infection is still worsened. And now there is only one option to treat, that is colistin. And so I'm just wondering, what if colistin is knocked out from the list too? We really have nothing here. So
Well,
here I have two questions for. Yes, sir.
yeah, go on.
I have
Go
two
on, sir.
questions for you, sir. Sir, like what is the major barriers you are facing right now implementing antimicrobial stewardship? So in this case, I have seen that the turnaround time for antimicrobial susceptibility test is 72 hours. It's been like 3 days. For me, it's like a barrier because conditions like sepsis, we need to act first. And second thing is hospital acquired infections are really critical, sir. Like you can see, extensive drug resistant pathogens are there. Like we call it as superbugs. So how can we tackle these situations, sir?
So, so Satya, you bring up a very interesting point again, right? Great question. So here is what I would say. Now, let's go. Your friend met with an accident, yes, and that is
Yes,
why
yes, sir.
he was in the hospital. No,
Yeah, yeah.
and within a day he became septic,
Yes, sir.
right? Okay, so
Yes,
there
sir.
are a few things.
Exactly.
So let's say so most blood cultures, most urine cultures will even at chance at UF, it takes us 3 days. Okay, so I think that is okay. And that is a huge barrier, but we'll come to that, right? And that's why in my slide, I spoke about point of care diagnosis and how much the gene expert has helped us today in diagnosing resistance much earlier. So we also have a method where we will, through, again, gene-based molecular testing, we will have something that tells us that if they have a MEC-A gene, is it a staph, is it coag-negative staph? But that's again, something that's been trialed. It's not really, large studies haven't been done. It gives us some guidance, but it really doesn't help. So to your question, it takes us 3 days as well, and that's okay. And it is okay to have patients on empiric therapy for those 3 days. If someone is in sepsis, it's okay to keep them on broad spectrum antibiotics until you get that data, which is 2 to 3 days, which is acceptable, or that's the best we have now, right? So I mean, we can't do anything else. The real question here is whether he needed antibiotics, right? Now, if your friend, again, I don't know, and this is making an assumption, I'm just giving you an example, but if your friend was a healthy person who met with an accident, unless the, even so was his shock related to something that was not infectious, right? And then you have the question of colonization versus true infection. Now, if you colonize someone's open wound, are you not going to grow a bacteria? Absolutely, yes. In a place where antibiotics are used extensively, if you culture an open wound, are you not going to get a bacteria that is resistant to everything? More than likely, yes. But are you going to treat? Probably not, right? What he needs is wound care. So without knowing the details of your friends, so really, if he crashed, if he met with an accident and within about 24 hours he developed sepsis, unless it was such a bad crash that had contaminated things all over it. I mean, it's difficult to say. The real question that when we get called for these things is we tell the teams whether you truly need antibiotics or no. And we say, you know what, this infection is this scenario you're seeing. Because remember, every time a patient's blood pressure drops, he can't breathe, it's not infectious, right? If you look at fevers, only 28 or 30%, and I don't have the exact number, but it's in that level of fevers of unknown origin are caused by infections. And how many times will you get a patient being treated with antibiotics for months and end because it doesn't get better, and it's probably something else, right? So the true question is whether he truly needed antibiotics, and he might have, because I don't know the case. But 3 days is okay, and that's what we do here. And colistin bacteria are already present, right? We know there have been multiple cases isolated with colistin resistant and CREs and such.
Yes, sir. Thank you so much, sir.
Oh, thanks, Satya.
Hello, good evening, sir.
Yeah, hi, Mushtaq.
Yeah, sir, I am Mushtaq, sir. I am a PharmD intern. Sir, I would like to ask you a question, sir. Usually, sir, what do you think about that antimicrobial resistance develops at our home, sir? Like when we fall sick, we don't complete the course of the drug. So it decreases this sensitivity, sir. So eventually, if we get a disease and we are admitted in the hospital, that the resistance makes our condition severe, sir. Sir, and second question I would like to ask you, sir, what do you expect from PharmD, sir, to tackle this antimicrobial resistance problem?
So great questions, both of them, right? So yes, I do not have the author's name, but there was a study that came out which said the water in Delhi's taps had NDMs, right? So you don't have to acquire these infections just in hospital. It's probably more prevalent in water and a whole, so it's much more complicated probably. So yes, if you do not, and that's the whole point, trying to convince someone to complete the course when they already start feeling better is a challenge. But I think where PharmDs, and I think that might be the most crucial thing, is again what Sunitha spoke about, forming teams with physicians, microbiologists, educating one another that, this is a dangerous thing that is happening when people are given antibiotics, even for viral infections. Let's be honest, how many people do we know who were treated with antibiotics for COVID-19, right? When we knew it was a viral infection. How, there are so many of these instances that come up. So it's, I think education, communication is very important. And I think pharmacology pharmacists, I think it's very important for you all to form teams with physicians, microbiologists, and work as a team. It's probably hard for people to accept that this needs to be treated in a multidisciplinary team approach, but I'm sure that will change over the next few years. But also educating your patients, educating your families, right? It's spreading the word around that this problem is true and real and needs to be tackled. It's much like misinformation or disinformation. Now, you get a WhatsApp chat, a WhatsApp message that, says a whole bunch of things. You're going to educate people who read it in your family, outside, that what the information is wrong. So probably taking a more proactive approach and being part of organizations, being part of that process of dissemination of this information of antimicrobial resistance is key, because a lot of people in India, right, visit the pharmacists as their primary mode of entry into the healthcare system, especially in probably remote areas. Pharmacists are literally the doctors taking care of patients. And so I think they have a huge role in furthering this information about antimicrobial resistance to the community itself and helping with that.
Thank you, sir. Sir, so can we quote like this, sir? Like, we bring resistance from our homes.
Well, it's difficult, right? And I don't know the data in India, so I wouldn't I wouldn't know about that. But I think, there might it might be true, it may not be true. But here is the thing, right? If you are bringing these bacteria from home and it's not causing an infection, it might be colonization. So it's I think a much more complicated process, and it's not very simple as such.
Thank you, sir.
Mushtaq, I would like to add, sorry, Karthik, I just wanted to add one other thing for Mushtaq's question of, where else can pharmacists or PharmDs contribute? I think as far as research is concerned, hospital-based research is concerned, and being part of, like what Dr. Gautam said, Medicines and Therapeutics Committee. So if research can be based as part of the Medicines and Therapeutics Committee agenda, then whatever is happening in the hospital, right from antibiotic consumption to any aspect you want to look at, which is able to optimize the use of antimicrobial agents, I think that's where, as PharmDs, you can play an active role in the clinical setup. So that was a quick point, Karthik. Please go ahead.
Yes, ma'am. So I was just telling we will not take more questions. You can always send those questions on my WhatsApp. I will forward it to speakers and get their answers and share it with you. So now I would be interested to take a couple of feedbacks, one for Sunitha ma'am session and one for Gautam, Dr. Gautam. And meanwhile, Alvin, you can keep the certificate ready. speakers and get their answers. Yeah, Samiksha, you can interact. Like you were telling something.
Yes, sir. I had one question, sir. Actually, I was waiting. One was similar to that how antibiotic stewardship is mainly considered in larger hospitals. So, as in India, we go for smaller hospitals and those clinics. So, how do we approach over there? And actually, that got resolved by as Mustaq question was the same. One other question, sir. There are some clinical case scenarios where there is use of 2 to 3 antibiotics together. And that shows as therapeutic duplication. But upon consultation, they were like, we can go with it. So I wanted to know, how do we understand that? How do we apply a standard guidelines that shows that we need to go with 2 antibiotics per case or based upon it? So how do we approach towards it basing upon the standard guidelines?
Right. So good question, right? So again, remember, guidelines, as I mentioned earlier, are just a guide. So it truly depends on the people or the team that takes care of these patients as to decide on the best therapy, the best mode of therapy, right?
Yes, sir.
Right. And so again, it truly depends on the patient, because the patient is the host, right? And the host has a lot of characteristics that may influence the pharmacokinetics and pharmacodynamics. Now, dual beta lactam therapy, probably not that good, right? Are you going to use fluoroquinolones in a patient with C. diff? Probably not very good. But that is something that the team decides. The pharmacist, the microbiologist, and the physician. And that truly depends based on the resistance mechanisms, if there is resistance present, if any, right? And other aspects, where the infection, the site of infection is very important, right? So if it's the brain, then, there are antibiotics that don't get into the brain. And so you want to make sure that those antibiotics are not used for endocarditis. The dose matters. Now, if it's endocarditis, are you going to use a low daptomycin dose? Probably not. You're going to go with a higher dose. Ceftaroline, bone infections, right? Penetration, all those matter. Like, what's the level of the antibiotic in that particular tissue? Is it the prostate? Is it the bone? Is it the heart? Is it the brain? Is it the eyes? Because some antifungals don't get into the eye, so you can't treat endophthalmitis. Right? So you would, when you say 2 antibiotics, and presuming you're talking about empiric therapy, and it's okay to cover someone with empiric therapy that covers both the gram-positive cocci, like staph, and gram-negatives. Again, anaerobes would depend on where the infection is present. If it's an intra-abdominal infection, you want to treat the anaerobes as well. If it's a diabetic patient with a diabetic foot ulcer, you want to treat the anaerobe. So it's I think it depends on a whole lot of things that include the pharmacokinetics, pharmacodynamics, and the ability of the drug to penetrate the tissue, which I think the pharmacist knows very well. It depends on the antimicrobial resistance, the MIC, the type of bug, which the microbiologist knows very well, and the host, what kind of conditions the host has, where the infection is present, which is, the clinical aspect is probably best, known by the clinician. So it needs a team-based approach to accurately kind of come up with a plan for this infection.
Yes. Okay, sir. Thank you, sir.
Oh, no problem.
Dr. Gautam and Sunitha ma'am, thank you so much for taking your time, and this is a small token of appreciation and gratitude from all of us.
Thanks, Karthik.
Thanks a lot. Really appreciate this. And anything to do with trees, really, it's one way of leaving things behind very well. Thank you.
And any student, if you can quickly share feedback on what you heard and what aspect would you like to implement in your practice to address this issue? So we'll be happy to take one feedback or two feedbacks.
Good evening, ma'am. Good evening, sir. Uh, Ma'am, I have found your session very thought-provoking, ma'am. I was actually very surprised to know that not until 2015 there was a momentum to monitor antibiotic resistance so much. And also, whatever you have mentioned about not pointing fingers at other professionals is also very true. For example, I am a student, though I may not be able to change the treatment regimens. I could at least help the people in my community or my family uh, by guiding them not to stop antibiotics after their symptoms got reduced. And also, one thing that really touched me in what you said, ma'am, is that in every crisis, you said we have a hidden opportunity. That was very special, ma'am. Thank you so much.
Thank you,
Uh,
Saishri.
Sir's session. Thank you so much, sir, for the session. It was very practical based, and it really shows the importance of guidelines and also where we pharmacists can also participate in uh, treating the patients appropriately by helping the physicians follow guidelines properly and also showing support to the patients during counseling and all. Uh, Thank you so much, sir, for the session.
Thanks, Ashri. It was a pleasure.
So Alvin, I think we can stop streaming on YouTube and have maybe some closed interaction, couple of few minutes if time permits for both the speakers.
I'm happy to stay back. I don't know about Dr. Gautam because he may have his clinic.
Gautam, actually,